All right, so we stopped at CPAP. I'm not testing CRT or the heart transplant, LVAD. I'll go straight to the teaching now. Complications first. Okay. The reason why I'm skipping those are not typically on the NCLEX because they are in the ICU setting or in cardiovascular ICU. So they're not typically things that a new graduate will encounter or be tested on. All right, so let's go with complications. So this part here is the same as chart 35-1. So this is evidence of pulmonary congestion. So the symptoms you saw in chart 35-1 are really the same as chart 35-3, except for the hypertension part. But pretty much this is fluid in the lungs. So the patient undergoes pulmonary or develops pulmonary edema as a result of specifically left-sided heart failure. How did this fluid accumulate in the lung? So the exact mechanism is because of increased hydrostatic pressure. So the more blood is congested in the left side, in the left ventricle, and then it backs up to the left atrium, and then backs up, will cause pulmonary vein congestion. And of course, the capillaries in the lungs wrapping each alveoli will also be congested. So all that extra pressure there in the vessels will eventually lead to leaking of water. And of course, that water will now accumulate in the alveoli. So each of the millions of alveoli fill with fluid, resulting in pulmonary edema. Okay, so but the exact mechanism here is because of congestion, because of increased hydrostatic pressure. And because each of those alveoli, millions of alveoli, are wrapped in capillaries, so therefore, along with water leaking out, there might be some blood also leaking out, as some of these capillaries may end up bursting, right? So there's some pink tinged sputum that may also be present. And the rest of these are related to, of course, can there still be gas exchange if the lungs are wet?
Not much.
No. Okay, so there will be decreased gas exchange, so leading to dyspnea, and then of course there will be hypoxia, so therefore there will be confusion, restlessness, lethargy. And these are your management for pulmonary edema. I'm not really testing this part. I will test pulmonary edema management under chapter 32, so not for this semester. But typically, the #1 treatment for pulmonary edema is diuretic therapy. Patient will receive Lasix. Next will be, okay, so we're about to discharge this patient now. This one is simply a summary of the signs and symptoms of heart failure, so I'm not testing that again. So I'll stick with chart 35-1 and chart 35-2. This one, though, is now for your discharge teaching. So a patient needs to know when do they call the doctor. So these are your teachings. You teach the patient their medications. The acronym is MODS. So we have medications. So that would be your doables, okay, particularly DOAB. So here's activity or under exercise. Here's monitoring weight and their diet. So sodium restriction, and then symptoms. As far as the symptoms go, because this one's not specific here, it just says, note any new or worsening symptoms. The new or worsening symptoms are listed here in an action alert, page 704. So again, these new or worsening symptoms to notify the doctor about are listed in an action alert here. So this is part of heart failure core measures. So you call the doctor when you have a rapid weight gain, 3 pounds in a week or 1 to 2 overnight. Decrease in exercise tolerance, cold symptoms more than 3 to 5 days. Because again, this is this added stress that I talked about earlier, because that will precipitate a decompensation episode or an exacerbation of heart failure. Excessive awakening at night to urinate, that only means that you're, what can you say about if the patient is now more, waking up more frequently at night? What can you say about their fluid status?
High.
They're in fluid overload.
Tension.
They're in fluid overload.
Now there's the excessive nocturia now. So this will be a sign that their condition is getting worse. Or development of dyspnea, or even chest pain at rest. Or if they normally have chest pain, so let's say the patient on top of heart failure also has angina, chronic stable angina, if it's worsening, of course that's reportable, and then increased swelling in the feet, ankles, or hands, also indicating increasing fluid overload. And then last teaching is if the patient's on beta blockers and digoxin, these are your teaching. So we covered 60 to 100. Again, our key here is 60. And they have to keep their appointments, whether for lab tests or to see the doctor. Here's an instruction about what happens, because this is something they do every day, and in the hustle and bustle of life, we may end up forgetting a pill every now and then. So these are your instructions. You can only delay it for a few hours, meaning 3-4 hours maybe, but if it's too late for the next dose, then don't end up doubling the dose. All right. And that's it. So we discussed this already, potassium and renal function for those taking diuretics, ACE inhibitors, ARBs, especially if they're on digoxin. So these are the rest of your teaching. All right. And we already covered the sodium restriction. These, of course, are more specific with foods that naturally contain potassium, like milk and milk products. So that would include cheeses, dairy, because they're naturally salty. Here's the commercial salt substitutes, which I already mentioned earlier. You only need to spend it. I mean, it's not ridiculously expensive to buy a non-potassium based salt substitute. Maybe they cost $2 more. That's it. It's not really that expensive. Or they can try these instead as alternatives to flavor their foods because of the salt restriction. And this part here are really if the patient has late stage heart failure, let's say stage 4. If you remember heart failure classification 2 weeks ago, class 1, 2, 3, 4. So if patient is in class 4, that would be the time to have a advanced directive, or to teach the family how to do CPR, or if the patient even desires CPR, okay, should anything happen to them. Any questions on heart failure before I proceed?
No.
All right, let's go to valve disease now. I will only test what's on chart 35-6. So we have, this chart only talks about two valves, the mitral and the aortic valve. Now, this doesn't mean that the patient won't have problems if they develop pulmonic or tricuspid valve problems, okay? This only means these are the two most serious problems. Why the mitral and the aortic? Miss Penny.
Yes, Professor?
Yeah, what's the importance of the mitral valve and the aortic valve? Why are they the only two mentioned in this chart? Or is this, yeah, chart 35-6. Why these two? Why not the ones on the right side, the pulmonic and the tricuspid? Why these two on the left?
The left side provides blood to the rest of the body, to the whole body.
All right, because the left side again determines cardiac output, and these two are the last two valves determining cardiac output, meaning there are two possible problems in valve disorders. A valve will either not open completely or not close completely. So we have stenosis or regurgitation. Prolapse has the same effect as regurgitation, meaning a prolapse also does not close. So in regurgitation and prolapse, in these two instances, the valve does not close. Now, and of course, in stenosis, it does not open completely. Now, we discussed this 2 weeks ago, wherein we're talking about heart failure. We discussed, we reviewed what is the direction of blood
Professor,
through the heart.
You cut out.
When we reviewed chapter 33 2 weeks ago, what is the normal direction of blood flow through the heart? In what direction are they moving?
From right to left.
All right, so there's only a forward flow, right? So coming from the right side, going to the left side.
Professor,
Is that,
I'm sorry, can I ask you a question real quick? You were cutting off when you were describing, I know you said mitral regurgitation and prolapse, they're similar because they stay open. You said stenosis doesn't open enough?
yeah.
Okay, I just wanted to make sure.
All right, so if there is any of these conditions, either a valve doesn't completely open or a valve doesn't completely close, are we maintaining that right to left direction of the flow? Only one direction, forward, no backward.
No, it's going backflow, right?
All right, so there will be congestion or even backflow of blood if you have a valve problem. So if any of these doors either do not completely open or do not completely shut, it will disrupt the forward flow of blood. It will disrupt the unidirectional flow of blood. As a result, what happens to cardiac output?
Decrease?
And what will happen to the pressures in one or more chambers?
Increase?
What will happen to the heart as a whole? This is chapter 35. So what is the title of chapter 35?
Heart failure?
Heart failure.
Right, so all of these conditions mentioned in chapter 35 all lead to heart failure. So on top of, actually this was listed on table 35-1. This is table 35-1. Do you see valvular disease?
Yes.
All right. So this is one of the causes of heart failure. I won't belabor the discussion of valve disease because again, the two main problems here is the valves either do not completely open or do not completely close. Regardless of the problem, though, what is the end complication of valve disease? What will the patient develop?
Heart failure.
Heart failure. So do we need to repeat what the signs and symptoms will be? Do we go about it all over again? Back up? Because if you look at chart 35-6, look at the signs and symptoms. It corresponds with heart failure. So these are the same symptoms you saw in charts 35-1 and 35-2. It's just a matter of where is the valve located. So most of these, as you can see, result in left side heart failure because these two valves are located where? Where's your mitral and aortic valve located?
Left side.
Left-hand
The
side.
left side. So that's why you see mostly these are left-sided heart failure. However, you also see right-side heart failure symptoms, right? You see neck vein distension, pitting edema. These are all on the right side, right? Meaning, do people with heart valve problems only develop left-side heart failure?
No.
No, they develop both left side and right side heart failure. Because is this something temporary? If you're, look at the causes. So let's look at the cause here. Mitral stenosis, for instance. What's the pretty most common cause here? So you have rheumatic fever, which is discussed at the end of the chapter. And then you have, look at the effects. If the patient has mitral valve does not completely open. So imagine what will happen. What happens to cardiac output in the first place?
Decreases.
Decrease. Meanwhile, what happens to the pressure inside the left atrium?
Increases.
What happens? Where did that blood come from that's supposed to enter and leave the left atrium? Where did that blood come from?
The lungs.
The lungs. So therefore, that's why you have pulmonary congestion. However, does it stop there though? Because the door from the left atrium to the left ventricle does not completely open. So will the congestion only stay on the left side?
No.
It will eventually end up on the right side. So that will explain all your signs and symptoms here. Okay, so the patient with, doesn't really matter. Look at all these conditions here. Whether it's stenosis, regurgitation, prolapse, all of them cause heart failure. I can't move the, maybe I can, okay. Same thing here, aortic stenosis, same thing, same symptoms. All right. Now, I won't deal with the what is this? The heart failure anymore because we just finished heart failure. So the questions on the exam will be the cause of each one. So chart 35-6, causes of each one, like right here for mitral stenosis, for instance, this one is caused by rheumatic fever. What about regurgitation? This one is caused by, rheumatic heart disease again.
Professor, what does rheumatic mean?
This is caused by an infection, typically Streptococcus. The same, have you heard of rheumatic fever?
Yeah. I haven't, no.
Okay, so this is, anyway, it's discussed later in the chapter. We'll discuss that.
Okay.
Right? But it is a Streptococcus infection, the same strep organism that causes your strep throat. It's the same thing.
Okay, thank you.
However, of course, the strep throat here wasn't treated or was undertreated. Usually this happens in the older generation. Nowadays, we're pretty good with treating strep throat. I mean, most people I'm saying, so there's still a few who are not educated about the importance of treating strep throat. Those are the people that develop rheumatic fever. And because rheumatic heart disease, the damage, the permanent damage here is on the valve. As you can see there, these are the evidence here under valve disorders. How many times have we had rheumatic heart disease so far? So here's one, mitral stenosis, mitral regurgitation, both attributed to rheumatic heart disease or rheumatic fever. This one though is not. Mitral valve prolapse, typically, this is Warfarin syndrome is a connective tissue disorder, or you're born with it. The problem is was at birth, right? Meaning you were born. It's congenital. Okay, so it's not attributable to some disease or some infection. Okay, so MVP. A good thing about MVP though is most patients have no symptoms. Typically, they will have problems later in life when these patients develop hypertension or become overweight or develop heart disease. Then the MVP matters, and then the MVP now has symptoms. I know of a close friend in California. He's a nurse. He's had MVP all his life. He's very active. He's excellent. He's naturally athletic. No symptoms whatsoever. He's already 47 now. Yeah, he's 2 years older. But I mean, he's still very active. No problems at all. I ask him occasionally, how are you? And he said never had problems with this MVP. This one is pretty serious. This is now the aorta. So of course, and look at the cause. It's usually from wear and tear. So unlike mitral stenosis and mitral regurgitation, which were caused by infectious disease of the heart, this one is simply wear and tear. Now, of course, what will contribute to this is, of course, smoking, hypertension, that will also add or make the condition worse. And aortic regurgitation, this one is also from infections of the heart, but not rheumatic, meaning not caused by rheumatic heart disease. This is another infection, which will be our next topic, infective endocarditis, or it could also be from birth, okay, present at birth, and also from another connective tissue disorder, like I said. Symptoms, it's easy. We have it on chart 35-6 already, which are failure. How we diagnose it is an echo. We take a picture of the valves, and there are two ways to do this, but the best way is a TEE, meaning transesophageal. So it's like endoscopy, but instead of going down to see your stomach, we're actually not going that deep. We're only stopping at the esophagus to look at the heart. So compared to a 2D echo, wherein the probe is only put on your chest wall, this one, the probe is inserted into your esophagus. So we have a closer view of your heart, especially your heart valves. The X-ray here will only confirm evidence of the heart failure already, like the enlargement of the heart, cardiomegaly. Interventions is, we already discussed that the problem is heart failure. So we treat heart failure, we do doables. However, the patient will need surgery. So here are your medications, same thing as heart failure. Let's go straight to the surgery now. If the doctor determines based on the TEE that the damage is pretty bad, and that it needs to either be repaired or, if beyond repair, then replaced. People with valve disease tend to be more prone to infection, specifically infective endocarditis, which is the next topic we are talking about tonight. So therefore, it's important to have them be put on prophylactic antibiotics before any dental or oral procedure. Now, if you look at older editions of the textbook, so let's say somebody here is using the 8th edition or the 7th edition of the textbook, it will say more than dental or oral. Older editions of the textbook will say it's also required for GI procedures. Let's say you'll have an endoscopy or colonoscopy, or also bronchoscopy if we're going down your lung. Not anymore. So the American Heart Association removed those recommendations, and they only recommend prophylactic antibiotic only for dental, specifically dental or oral procedure, which means which one is more dirty according to the American Heart Association. Meaning these procedures are so dirty, so bloody, that they will cause a blood infection. So if they remove the GI and respiratory procedures and only left dental or oral, are they saying that the mouth is dirtier than your rectum?
That's what they're hinting at.
That's what exactly what they're saying. So therefore, dental procedure doesn't matter whether you're having a tooth canal, or a root canal, or just having a tooth cleaning, for instance. They didn't say it. They just said any dental procedure, which includes cleaning, right? So even when you have cleaning, though, is there blood involved when you have your teeth cleaned?
Yes.
Yeah.
Yes. Okay. So therefore, this is the #1 risk factor for getting an infection. So therefore, they put you on prophylactic antibiotics if you have a valve disorder. And it doesn't stop. Later, after surgery, because you had a valve problem, which even if it was repaired or replaced, the prophylactic antibiotic here before any invasive dental or oral procedure continues on for life. Is that clear?
Yes, Professor.
Alrighty. Again, the American Heart Association stopped this already. Okay, so no more GI, GU, or even respiratory. All right, so only dental and oral procedure as far as prophylactic antibiotics. Okay. All right, so the rest of these are the same again, heart failure. So if you read that, that's the same as what we did earlier. Let's go now to surgery. Oh, if the patient develops Afib as a result of valve disorder, if you've seen the commercials on TV, they say, anyway, there are options now for Afib. So Afib can be treated with warfarin or the novel oral anticoagulants. Okay, novel meaning new, just like the coronavirus. Okay, so these are new anticoagulants. They are 10A inhibitors. They're not like warfarin. Warfarin is a vitamin K antagonist. So these ones are newer anticoagulants. They're preferred because they are more convenient. Unlike warfarin, which requires routine blood monitoring of your PJI-NR, and there are diet restrictions. You can't take foods, you can't eat too much of the foods that have vitamin K, because vitamin K is the antidote for warfarin. So you can't eat too much of the antidote. So making these newer drugs very attractive to not only doctors but the patients. However, the number one contraindication for these drugs is if the AFib is related to a valve disease. So if these patients, because most of them do, if a patient with valve disorders develop AFib and they need anticoagulation, what drug can only be used? Hello?
Say the question again, Professor.
All right, so I said because of the valve disorder, it will cause congestion, correct?
Yes.
Leading to heart failure. All right, because of that increased pressure in the atria, it tends to promote the development of a dysrhythmia, which is atrial fibrillation. If, however, AFib can be treated either, not AFib itself, but because AFib causes clots to form because the atria are not contracting, so the patient is highly likely to form blood clots. They will be put on anticoagulants. The choices are for AFib, anticoagulation for AFib are warfarin or these novel oral anticoagulants right here. What I was saying is these novel oral anticoagulations, unlike warfarin, do not require routine blood monitoring. They have no diet restrictions. Warfarin needs regular PT-INR once a week, and also there's a restriction on the amount of vitamin K rich foods that you can eat. However, despite the convenience of these drugs, they cannot be used to anticoagulate AFib caused by a valve problem. So you've probably seen in commercials, but we're not aware. The commercials go, I have AFib, a type of irregular heartbeat not caused by heart problem. Okay, so my doctor suggested Xarelto, or my doctor suggested Eliquis. Sound familiar?
Just like the professors. Yeah.
All right. So, however, again, that's a warning though. So, if the patient with AFib and the AFib was caused by a valve problem, unfortunately, these nice anticoagulants cannot be used. Why? Well, because the drug company said so. In their clinical trials, when they used them for both regular AFib and AFib caused by valve disease, those with valve disease with an AFib did not, they still form clots, meaning the drugs did not work. All right, that's simply it. During the clinical trials, it did not work. So that's why their warning is, if the AFib is caused by valve disease, do not use our drugs. That's simply what they said.
Okay.
All right, let's go now to surgery. So valves can either be repaired or repair, no problem, they repair it. However, they do that. Replacement though, we have come a long way. We now have minimally invasive techniques. Used to be valve replacement can only be done by cracking your chest open. It is done by open heart surgery, just like CABG or coronary artery bypass graft. Now they can do it in the cath lab. So this is the latest procedure. They use TAVR now, transcatheter valve replacement. So they can go through either your femoral artery or your radial artery. Imagine the advancement of this technology, meaning you can be out in 1.5 days. You're out of the hospital, right? Whereas before, you have to undergo valve replacement with open heart surgery, wherein you'll have to be in the hospital for at least a week, be in rehab for 6 months to a year, and be on, the recovery is so long. Whereas after TAVR, you're out of the hospital in 2 days. Right, so we've come a long way. Plus, before, of course, it was open heart. So if a patient was over 80 years old, they were just told, "Sir, you're too old. We can't do open heart surgery. We cannot replace your valve." Not anymore. So people are living longer now. Of course, that would mean more cost for Medicare. I'm not saying life isn't worth it, okay? I'm just saying this will increase, you know, it has implications on everything. So let's go to replacement, because our nursing care here, we're not talking about the procedure, okay? So that's why I'm skipping over the procedure. Who cares how they do it? It's really the nurse's job is after the procedure. Okay, so repair, no problem. They repair it. So they have the same heart valve. Replacement, there are two choices here. They can either use biologic valves like these, made from either a cadaver or from animals, either a pig or a cow. Or they can do mechanical valves. Okay, they have titanium or other metal alloys. Okay, the post-op management will be different. Right here, if a patient develops, receives a biologic valve, they typically do not require anticoagulation afterwards, because the valve used was biologic. So since it's from organic material, you know, from a living tissue, they tend not to attract clots because they're not technically foreign objects. However, if the valve used to replace it is mechanical, of course, that's titanium or other metallic material. Of course, it's non-living, it's a foreign material, so it will attract platelets, thereby causing, possibly causing blood clots to form. So the patient will be on lifelong anticoagulation if the patient is received a mechanical valve. And like we said earlier already, since it's a valve, it's an artificial valve, and just like Afib, which is related to a valve problem, this one's also a valve, although there's no Afib here, but because this one will cause a blood clot, they will require anticoagulation, so therefore we cannot use the novel oral anticoagulants again, okay, because this is again a valve. Only warfarin will be used. We will discuss warfarin on chapter 36, possibly next week. If we finish, we should finish infectious diseases. It's already 10:35. We will stop with valve disorders. Again, let's recap. So valve disorders, we'll only be testing chart 35-6, beginning with the signs and symptoms, which should be easy because they are all heart failure signs and symptoms, left side and right side. Next questions on the test are causes. What are the most common causes of stenosis, regurgitation, and MVP, and aortic stenosis, and aortic regurgitation? Next are the, this one's testing, so that's only TEE. However, if you ever get a question on the NCLEX on this one, since this is transesophageal, this is endoscopy pretty much. So preparation here would be the same as a patient going into to get an endoscopy, right? So patient's NPO for about 6 hours. Yeah, that's about it. For drug therapy, we already discussed doables because these patients develop heart failure symptoms, so we treat them the same way. Next is the complication of the problems are Afib. All we need to know right now is the anticoagulation required, because there are two problems with Afib here. One is loss of cardiac output, and the other one is formation. We will not discuss the management of converting Afib to sinus rhythm, because that's chapter 34.
Professor, you're cutting
Yes.
out again. So I heard you saying about you were talking about the cardiac output is the one.
Yeah, so you didn't miss anything, because what I said was questions on exam 2 will only be on anticoagulation, because this patient will have clots if they have AFib, so they'll be put on anticoagulants. But again, because the cause of the AFib here is a valve problem, we cannot use anything else except what drug again? What is the only anticoagulant used?
Warfarin?
Only warfarin. So you can skip these antidysrhythmics here, calcium channel blockers, digoxin, because they are you, and cardioversion. We'll discuss all that in chapter 34, 2 semesters from now. Okay, so you can skip this paragraph right here. That's chapter 34, right?
Okay.
So here's the warfarin again. So this is our anticoagulant use. Again, we cannot use these drugs here, unfortunately, because they are the AFib here is caused by valve problem. And the next topic is on surgery now. So the patient will have either repair or replace. As far as replacements go, there are two choices. The patient either receives biologic or mechanical. You may ask me, which you didn't, why would the doctor choose biologic versus mechanical? Biologics needs to be replaced typically about every 10 years. They don't last forever. Mechanical, though, I mean, even decades after you die, that is still viable, okay, because it's made of metal. I don't really know, I'm not a doctor, so I can't answer why you choose biologic versus mechanical. However, our concern is if the patient receives a mechanical valve, they will require lifelong anticoagulation. So again, biologic valve replacements, they have little risk of clot formation. So therefore, do they need anticoagulation?
No.
No. Long-term anticoagulation is not indicated. However, because they are biologic, anything alive will have to die eventually. So they have to be replaced every about 10 years, 7 to 10 years. However, if again mechanical valve is used, they will require lifelong anticoagulation. If the patient has a mechanical valve, lifelong anticoagulation, what drug is used again? Only
Warfarin.
Because again, this is a valve problem. We cannot use novel oral anticoagulants. One last thing is don't forget the prophylactic antibiotics. Okay, so whether it's biologic or mechanical valve that was used as a replacement, doesn't matter. The patient has a valve problem, although it was solved by The valve or valve repair doesn't eliminate the risk that arthritis or infective endocarditis. So therefore, we require lifelong prophylactic antibiotics. Okay, let's go back to heart failure. So is heart failure cured after the valve replacement or valve repair?
No.
No. What did I say about heart failure earlier?
It's permanent.
Yep, it's forever. What's the only cure for heart failure?
Palliative treatment?
No, cure.
Heart replacement.
There is one cure.
There's one.
Oh, a transplant.
Transplant.
A heart transplant. That's the only cure. Heart failure is a chronic condition. You cannot, even if you control or treat the underlying causes listed in table 35-1, heart failure will stay because it is a permanent damage done to the heart or as a result of those causes listed in table 35-1, including valve disorders. Any questions? We'll discuss all these anticoagulation things under chapter 56 because it makes more sense there when we discuss DTs, which is also treated with anticoagulation. All right, that's it for this week. I already knew you'll be tired